front and below the curve. Look at it. So this is the position of the rectum. Are you clear? Hello, class. Hello.
Yes,
So this is the rectum and it is its position. So it measures from 12 centimeter long and 4 centimeter wide. And in the lower part, it has dilatation that is known as ampulla, the rectal ampulla. So it has two curvature, anteroposterior and lateral. Anteroposterior curvature, you are getting that this is sacral curve and this is perineal curve. Look at it. This in front of sacrum, so this is the sacral curve, whereas this bulging, this is the perineal curve. Talking about the lateral curve, it has upper, middle, and the lower curve. So we will will study details about this upper, middle, and the lateral curve. So talking about the curve, look at it. This is the upper convex. It is towards the right at the junction of this is upper, middle, and the lower curve. Okay. So this is upper, middle, and lower curve. It is towards it is upper curve is convex towards the right at the junction of third and fourth sacral vertebra. Whereas this middle curve is most prominent. It is also convex. It is towards the left side at the level of sacrocolpopexy. Convex towards the right at the junction of the coccyx. So these are the three positions at the three levels, so upper, middle, and lower. So what are the principles of the curve? So concavity of the curve. Concavity of the curve represents the rectal curve. Look at here, there are the rectal curve and which supports the base. Okay, are you clear up to here? The class. Hello, student, are you here?
yes, ma'am.
I have to repeat this. I'm doing fast or it's okay? Look at it. This is the rectal position. So upper one third in front is covered by peritoneum, and middle one third one is covered by peritoneum, and in the lower part it is covered by perineum. Look at it, this is blue color, this is the peritoneal bone. Whereas in the posterior surface, look at it, it is in the posterior surface, it is entirely non-peritoneal. So this blue color is peritoneum. So it covers upper one third in front and at the side, middle one third in front only, and in the lower it is devoid of peritoneum. There is no peritoneal fold. And posteriorly, it, it doesn't have any peritoneum. So this peritoneal fold will form different pouches. So that is in case of male and in case of female. So in case of male, this is rectum, this is vesicle, urinary bladder. So this is rectovesical pouch. Look at here, this is rectovesical pouch. And in case of female, this is recto-uterine. This is uterine cavity. So this is rectum. So this is recto-uterine pouch. We'll, uh, we'll discuss about the pararectal portion in next slide. Okay. So these are the fold forming by the peritoneum. Are you clear up to your class? Hello, students. Oh my God. So, so rectovesical and the recto-uterine pouch. So there are visceral relation of the rectum is very, very important. It will come in MCQ and in the theory also. So in case of male, anterior relation, what are the anterior relations? So first I told you this is rectovesical pouch in front of the rectum and this is 7.5 centimeter above the anus. So above the anus, you'll get this pouch 7.5 centimeter above the anus. And in the anterior relations, you can see sigmoid colon and the small intestine. So anterior relation is sigmoid colon and the small intestine. Whereas this, we are talking about the upper one third. So this in the upper one third of the rectum, these are two structures: sigmoid colon, small intestine, and rectovesical pouch. Whereas similarly in the lower one third, this is the lower one third. What are the structure related to here? Is look at your urinary bladder, seminal vesicle, vas deferens, prostate, and rectovesical rectovesial fascia of the inferior. These are the lines I can't show you over here. This rectovesical fascia of the inferior is somewhere between here. This line, so this may be the rectovesical. Okay, are you getting me? So these are the anterior relation you'll get in the MCQ question also. So this is divided into upper two third and lower one third. So upper you third, yeah, two third you are getting this three, whereas in the lower one third you are getting urinary bladder, seminal vesicle, vas deferens, and prostate. Okay? And these all structures are separated from the rectum by the rectovesical fascia of Denevere. Okay. Are you clear? Are you clear up to here?
Yes,
Oh my
ma'am.
God. So in case of female, look at in case of female, it is again divided into upper two third, and you are getting rectouterine pouch in the upper two third. This one is rectum and the unibatus. This is rectum and the uterus. So this is rectouterine pouch, and this pouch is 7.5 centimeter above the anus, where 5.5 centimeter above the anus and 7.5 cm above the external orifice of vagina. So this also you have to remember because this will be asked in the viva and the MCQ. So similarly in the lower one third, look at it. This is the lower one third, and it consists of this is uterus, so this is cervix, this is vagina. So what you are getting posterior surface of vagina and rectovaginal fascia. So this is the rectovaginal fascia which separate this posterior surface of vagina from the rectal ampulla. Okay, so this is the rectal ampulla, this is posterior surface of the vagina, and this rectovaginal fascia will separate this. Okay, are you clear? Hello, class. What happened?
Yes,
Nobody.
ma'am.
Only one person is responding. Anyway, this is the posterior relation. Posterior relation is again divided into three in the midline, on each side of the rectum, and lateral. So, in the midline, what are the structure you are getting? So, you are getting three pieces of sacrum, anococcygeal raphe. This is the anococcygeal raphe, and medial sacral vessels, and superior rectal artery. So sometimes you'll ask in write short notes on posterior relation of the rectum. So you have to draw these pictures and you have to write. In the midline, you are getting, I'll repeat this, lower three pieces of sacrum, coccyx, and anococcygeal raphe. Similarly, medial sacral vessel and superior rectal vase artery. Okay, on each side. On each side of the rectum, you are getting piriformis muscle, coccygeal muscles, levatriani. Okay? And you are getting sacral plexus of north, sympathetic trunk, and pelvic splenic nerve. Okay, you are getting what you are getting as three muscles and three nerves. Look at your. I'll repeat it this again: piriformis, coccygeal, and levatriani. Three muscles. Okay, and again, what about the plexus? Sacral plexus. Okay, nerve. Sacral plexus, sympathetic trunk, and pelvic splenic nerve. Okay, through three muscles, three nerve, and posterolaterally, what you are getting is it is again divided into three parts: upper one third, middle one third, and lower one third. So in the upper one third, you are getting pararectal foci, sigmoid colon, and small intestine also you'll get. And the middle one third, you are getting pelvic rectal space and the levator muscles. So this is the levator muscle, and lower one-third you are getting the ischiorrectal fossa. So this is the posterolateral relation. I clear about three relations, student.
Yes, ma'am.
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
I'm going faster. It's okay.
Okay,
Hmm?
ma'am.
It's okay. You people are sleeping or you are observing the sliders. So this is pararectal foci. This is small intestine. This is the relation. All the relations showing this in the midline. Okay. If you see in the east side, you can see the pararectal foci like this. Okay. So now we'll move on to the interior of the rectum. In the interior of the rectum, you'll get the mucosal fold, and there are longitudinal fold which is temporary. When the rectum stress, it can be disappear. But there are transverse fold. That transverse fold are what? They are permanent fold. Okay, in transverse fold, you are the example of transverse fold is the Austrian valve also. So it is irreparable. It is permanent fold. What you have to say is it has temporary fall and permanent fall. So we'll talk about the permanent fall. So what is Houston fall? Look at here. It is formed by the reduplication of mucous membrane containing soft mucous tissue and the circular muscle of the rectum. So this is the permanent valve, or it is known as the Houston valve. So there are three valves. So look at it. This is first valve. First valve, it is close toward the retrosigmoid junction at the level of S3. Okay, and it is 12 to 14 centimeter above the. It is 12 to 14 centimeter above the anus, and it arises from right or left side of the gut. It may be in the right side or it may be on the left side. Okay. Now we'll talk about the second valve. So second valve, it is 2.5 centimeter above the third valve. Third valve is the constant valve. Okay, and this is the third valve. This is second valve. So this second valve is 2.5 centimeter above the third valve. It lies on the upper convexity of the lateral valve. Okay, so this is the second valve. Now we'll talk about the third valve. So this valve is constant valve. It arises from the anterior and right wall of the rectum along the convexity. Look at here. This is the convexity. So I told you this is upper, this is middle, and this is lower. So this valve along the convexity of the middle lateral. Look at it. This is middle convexity. So it opposite the middle convexity, you are getting the third bulb. This bulb is also known as Nelanton sphincter, and it lies opposite the S5, or it is about 5 centimeter above. Now this is the fourth bulb. It is 2.5 centimeter below the third valve and arises from the left lateral wall of the rectum and along the lower convexity. Okay, I'll repeat this again. This is third valve, this is constant, and this is second valve, this is the fourth valve. So this second valve lies along the this upper convexity, in the middle of upper convexity. So this is upper convexity, upper lateral convexity. Now this third is opposite the middle of left lateral convexity, and fourth one is opposite the upper lower lateral convexity. You are getting me? So this you have to assume this third valve, and it is constant valve. So 2.5 centimeter above is third valve, and 2.5 centimeter below is the fourth valve. Okay, and so this is first, second, third, and fourth valve. First can arise from right side or left side. Both it can be, but second always come from left, third always come from right, and fourth always come from left. I clear about the valve,
Yes, ma'am.
students. So you have to, when you have to write about this valve, right short nose and valve, you have to draw this convexity, upper lateral, middle, and lower convexity. On the middle of upper right, you have to draw second valve. On the middle of this middle convexity, you have to draw third valve, and this fourth one on the upper right convexity. So these are the valves. This is called Houston valve. And what is this function of the valve? This this valve holds the fecal material in the position. So this third valve, look at it. This third valve divides this rectum into upper part and the lower part. So upper chamber contains the feces without the reflex act of the defecations, whereas lower chambers defecation, if the stool reaches the lower chamber, if the stool reaches this lower chambers, then defecation starts spontaneously. Okay. So what are the importance of Austen valve? So it supports the weight of the feces. It prevents the passage of instrument from the anus, and it to provide the injury of the third valve. Cannula of rectal washing is passed in the left lateral position. Patient is asked to sleep in the left lateral position, and cannula is passes for the rectal washing. Why? To avoid the injury to the third valve. Okay. So blood supply of the rectum. So it is supplied by superior rectal artery. Look at it. It is the continuation of the inferior mesenteric artery. This is the principal artery of the rectum. Whereas it is again supplied by middle rectal artery. It is the branch of internal iliac artery. Whereas it is supplied by inferior rectal artery. This is the branch of internal pudendal artery. Please remember the where does it arise from? Okay, it will be asked in the MCQ, spotters, viva, anything. Superior rectal from inferior mesenteric, middle rectal from internal iliac, and inferior rectal from the internal pudendal artery. So venous drainage, look at it. Suprarectal vein from upper part, all the vein joined to form the suprarectal vein, and it will drain into the inferior mesenteric vein. Similarly, this from the middle part, inferior middle rectal vein. It is joined and it convey into the internal iliac vein, whereas this inferior rectal from the lower part drain into the internal pudendal vein. So this superior rectal inferior mesenteric vein is it is the vein of portal system, whereas this middle rectal and inferior rectal is the part of systemic vein. So portal travel anastomosis occurs towards the rectum. You are getting me? So portal vein, this is portal vein, and uh, this as a systemic vein. This vein to anastomosis. So this forming the protocaval anastomosis. Oh, this is the one of the site during portal hypertension, and this is the site. Rectum is the one of the site for the protocaval anastomosis. You are getting me or not? Hello, class.
Yes, ma'am.
So venous drainage, look at it. This rectal veins are arranged in the form of plexus. It is known as annulus hemorrhoides. So this plexus form two set of plexus, that is internal venous plexus. Okay, this is internal venous plexus and external venous plexus. Internal venous plexus surrounds the anal canal above the Hilton lines. I'll talk about the Hilton's line in next slide. Between the mucous membrane and the internal sphincteric muscle. This also I'll tell you, this is the internal sphincteric muscles. It drain mainly into the superior rectal vein. Okay, this internal venous plexus drain into the superior rectal vein, and it communicates freely with the external plexus also. Thus, it communicates with the middle and inferior rectal vein. So this is the site important communication between portal and the systemic vein. I told you in previous slide. Another set of venous plexus is external venous plexus. So external venous plexus, what will happen? It surrounds the anus. Okay? It surrounds the anus between perianal skin and subcutaneous parts of the external sphincter muscles. This external sphincter muscle and internal sphincter muscle will come in next slide. Okay, so this is internal and the external sphincter muscle. Okay, so another vein is anal vein. They are arranged radially around the anal margin. Excessive straining during the defecation may rupture of this vein, forming subcutaneous perianal hematoma or external hemorrhoids. This is, as I told you, it surrounds the anus between the perianal skin. Look at your skin and subcutaneous tissue. So this is the external piles. So what you have to remember is venous drainage of rectum is very important because it is forming the protocaval anastomosis and venous drainage veins are arranged in the form of two plexus, that is internal venous plexus and external venous plexus. Its internal communicate with the suprarectal vein. External also form the anal worm vein will form around the anal canal and it can cause the external hemorrhoids. Okay. So lymphatics from it is again divided into three parts: upper part, middle part, and low part. Upper part drains into the late common iliac node and pararectal nodes, where middle one will drain into the internal iliac nodes, whereas lower part will drain into the superficial inguinal lymph nodes. So this lymphatic drainage, you just see the pictures and you study by yourself. Now nerve supply, it is derived from sympathetic fiber and parasympathetic. Sympathetic is derived from suprahypoglossal plexus, that is from L1 and L2. It stimulates the internal sphincter muscle and inhibit the rest of the musculature of the rectum. Whereas parasympathetic by the pelvic splenic knob. Please remember this pelvic splenic knob S1, S2, S3. It is secretomotor to the gland and stimulates the peristaltic and relax the sphincter. It stimulates the sphincter with it will relax the sphincter. Now, what are the supports? Look at it. This is the puborectal sling of levator ani and reflection of pelvic fascia, facial seat of Waldeyer, and pair of lateral ligament of rectum, pelvic rectal and ischiorectal fascia flats. So you have to see this sling, puborectal sling of the levator ani is pulling the rectum. And these are all the reflections which keep the rectum in position. In applied colonoscopy for see prolapse of the mucous membrane only. Here, the rectum will itself prolapse from the anal canal. Colonoscopy, what will done to see the colon from the anus, all the instrument is passes and all the structure of this large intestine is seen. In the clinical anatomy of the rectum, the digital Paul rectum or PR examination, finger is interest and rectum is palpated to see the what are the structures. Fecal material is impacted, foreign material is present or not. In the rectal wall, you can see the rectal growth, sphincter, thrombosis, piles, you can see. And outside the wall, you can see distended bladder, lower uteric stone. And protoscopy and schemoscopy also done. Protoscopy shows the internal piles and growth of the lower part of the rectum, whereas sigmoidoscopy helps to reveal the ulcer growth and diverticulum, and it is taken for the rectal biopsy also. So carcinoma of the rectum, it is situated at the retrosigmoid junction or in the ampulla. So this is PR is done to see the rectum from inside and outer. Are you clear of the rectum? Hello, class.
Yes, ma'am.
So we are talking about the anal column. So this is the anal column. Look at it. It is the terminal part of the large intestine. It is 3.8 in centimeter and it extends from rectum to the anus. So anorectal junction to the anal orifice. So this is the anal canal. So interior of the anal canal, this is very important. Look at here. This interior of the anal canal is divided by this pectinate line and the Hilton's line. Pectinate line will pass from here. Pectinate line and the Hilton's line, these two line will divide this interior of the anal canal into three parts. That is upper mucous part, that is 15 mm, middle mucous part, pectin part 15 mm, and lower cutaneous part. Okay, first you have to remember pectinate's line and the Hilton's lines. This divides the interior of the anal canal into upper mucous part, middle mucous part, and lower cutaneous part. So talking about the Hilton's line. So look at here this Hilton's line. It is the color contrast between the bluish pink area above and black skin area below. So Hilton's line. This is again the MCQ question. It represents the anal intersphincter group at the lower end of the internal sphincter muscle. So this is the internal sphincter muscle and this is external. So it's represent the lower end of the internal sphincter muscle. So or simply what is you have to say it is the color contrast between the bluish pink and the black skin. Okay? And what are the importance of the Hilton's line? So it is the lower end of the internal sphincter muscle. So this is the muscles and anal fascia and lunate fascia will extend up to this line. Anal fascia and lunate fascia. So are you clear about the Hilton's line? Class.
Yes, ma'am.
What about boys? What happened? They are sleeping or what? They are not interested or what? Nobody responds. Ki boy? Hi. Hello? Hello?
Yes, ma'am.
Yes, ma'am. Oh, yes, ma'am. Prozul, ke
Yes,
boy?
ma'am.
Yes, ma'am.
Ma'am.
Ki નથી બોલે તો monotonous boy ki you don't understand or what? Are you clear up to Hilton's line?
Yes, ma'am.
So this is the Hilton's line. Now, so we'll talk about the upper mucous part. So it is lined by simple columnar and it has 6 to 10 vertical folds, our anal column. So look at here, this is the anal column or canal of Morgani. So it's in the upper mucous part, you'll get the anal column and the lower end, it is united by this anal column is united by the anal valve. So these are the anal valve. Look at it. These are the anal valve. And in anal valve depression, you are getting the in the depression you are getting the anal sinus. First, you have to know about anal column. Then this is anal valve, and in the anal valve, you are getting the depression anal sinus. Okay, so these are the anal sinuses. So anal gland receives the sinus from the duct of the anal gland. So anal valve, you can see anal gland. So these are the lines. So this anal valve, look at it. This anal valve will represent the line. This dotted line, look at it. This dotted line. This dotted line is called the pectinate line. Look at your pectinate line. This anal valve. First, what we have to remember, pectinate line and the Hilton's line divides into three compartments. So we are talking about the uppermost part, upper mucous part. We are getting anal column, anal valve, anal sinus. So what is this anal valve will join together and it represents the line that is called the pectinate line, or you can say dentate line. Also, look at here. This is the anal valve, and this line, this yellow color line, is the pectinate line or dentate line. So this pectinate line will divide again the this rectum into upper part and lower part. Okay, so it is the mucocutaneous junction, and it represents the it corresponds with the anal valve, and it divides the anal canal. Sorry, rectum. It divides the anal canal into upper part and the lower part. So it is developmentally also it is different. Upper part is it is endodermal, and lower part it is ectodermal origin. Okay, and upper part it is supplied by superior rectal artery and vein, whereas in lower part you are getting the inferior rectal artery and vein. Lymphatic upper part into the internal iliac lymph node and lower part into the superficial inguinal lymph node. Upper part autonomic nervous system and lower part is somatic nervous system. Hello, hello,
Yes,
class.
ma'am.
Yes,
Yes, ma'am.
ma'am.
Yes, ma'am. Yes, ma'am.
Okay, middle mucous part. So this is the middle mucous part. It is lined by. So in exam, you have to write short notes on pectinate line. Then you have to divide this, and you have to write all this developmental, blood supply, lymphatic, and nerve supply. Okay. So we'll talk about the middle mucous part. It is lined by non-keratinized stratified squamous epithelium. It lies between the pectinate line and the what I told you. This is pectinate line, and this is what Ilton's line. So this is the middle mucous part, and it is surrounded by internal rectal venous plexus. So it is richly supplied by vessels and somatic nerve vessels. Now we're talking about the lower cutaneous part. It is truly lined by skin. At the anus, it is dry, and hair is present over here. So, what about the musculature of the anal canal? Anal sphincter, look at here. This is external anal sphincter and this is internal anal sphincter. So, what I told you about the muscles, so look at it. This is the external anal sphincter muscle and this is the internal anal sphincter muscle. So anal sphincter, internal anal sphincter, this is the internal anal sphincter muscles and it is involuntary in nature. It surrounds the upper three-fourths of the 30 mm of the anal canal extending from the upper end of the canal to the Hilton's line. So this is the internal anal sphincter. It extends from here up to the Hilton's line. So Hilton's line represents the lower end of the internal sphincter muscles. Are you clear? This Hilton's line will represent the internal anal sphincter muscles. So most another is external anal sphincter. So in external anal sphincter, it is the voluntary control. It is made up of striate muscles and supplied by inferior rectal nerve and perineal branch of the fourth sacral nerve. And it surrounds the length of the anal canal and it is again divided into three parts. External anal sphincter is divided into three parts. Look at here. This is first one is subcutaneous, another is superficial, another is deep. So, talking about the subcutaneous, it lies below the level of internal sphincter muscles and surrounds the lower part of the anal canal, whereas superficial part it arises from the coccyx and anacoccygeal ligaments, whereas deep part it surrounds the upper sphincter and fuses with the puborectum. This you have to remember is this figure, internal sphincter and the external anal fissure. It has three parts. That what are the three parts? Subcutaneous, superficial, and deep part. Okay. So nerve supply is very, very important. Look at here. Above the pectinate line, it is supplied by autonomic nerve, both sympathetic, that is inferior hypogastric plexus, and parasympathetic pelvic splanchnic nerve. The upper area is insensitive to modality of cuteness. That is because of this pelvic splanchnic and autonomic nerve. This area is insensitive to pain. You can't feel any pain. But below the pectinate line, it is supplied by somatic or inferior rectal nerve that is S2, S3, S4. So this area is sensitive to pain. Please remember this upper area above the pectinate line is supplied by autonomic nerve. So this area is very sensitive to this is not sensitive to pain. Similarly, this below the pectinate line, it is supplied by somatic nerve, so it is sensitive to pain. You are getting me? Hello, class.
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Just so this is insensitive to pain. Wait, this is sensitive to pain. So talking about the sphincter muscles, internal sphincter is caused to contract by sympathetic nerve and relaxed by parasympathetic nerve, whereas external sphincter is supplied by infrarectal nerve and perineal nerve. Okay, so this nerve supply is very, very, very important. Talking about the applied, you can see the anal fissures. Damage to this valve. Damage to this valve, what will happen? You can see the anal fissure. So this is the anal fissure. This is very painful condition. Anal fistula. So you can see the anal fistula fibrous tract communicating the two surfaces, anorectal mucosa and the skin. So you can see the anal fistula communicating to these two area. This is fistula. And talking about hemorrhoids. Now, you must have heard about the piles or hemorrhoids. There are internal hemorrhoids and external hemorrhoids. So, internal hemorrhoids. Look at here. This is the internal hemorrhoids. It is distended and varicose vein above the pectinate line. So above the pectinate line, you can say distended and varicose vein that is called internal hemorrhoids. If internal, if it is distended, you can see bright red color. And as this area is insensitive to pain or modality to cutaneous sensation due to the splenic innervation, so only if internal hemorrhoids is present, what will happen? Patient doesn't complain of any pain and bleeding will occur. That bleeding is bright red in color. Okay. Why it is insensitive to pain? Because of the autonomic nervous system, splenic innervation. So patient doesn't feel any pain. Whereas external hemorrhoids, look at here, this external hemorrhoid, it is the distended varicose vein below the pectinate line. External hemorrhoid are covered by skin, as I told you, and it is extremely painful due to the thrombosis and rupture of the small perineal vein, and it is supplied by the somatic innervation. Okay. So, what is the difference between internal hemorrhoids and external hemorrhoids? First one is internal hemorrhoids is occur above the pectinate line and it is supplied by autonomic nervous system and bleeding occur is bright red in color. Okay. Whereas external hemorrhoid it covers the skin perianal space and it is supplied by somatic nervous system, so it is very painful. Okay. And bleeding also it's not bright red, it is dark red in color. So classification of internal hemorrhoids, it is divided into three degree: first degree, second degree, third degree, and fourth degree. First degree, look at here, above the pectinate line and no prolapse, just prominent of blood vessels. I'm talking about internal hemorrhoid classification, okay? And second degree, prolapse upon bearing down and spontaneous reduce. It will prolapse, bearing down, and it will spontaneously reduce. Whereas third degree, it prolapse upon bearing down and it requires manual reductions. And if manual reduction is done, it is go above. But the fourth degree, look at here, it's prolapse and cannot be manually reduced. So these are the four classification of internal hemorrhoids. So in total obstruction, you can see distension of suprarectal vein through the anal canal and cause the internal hemorrhage. Okay? At the side of 3 degree, 3, 7 and the 11 o'clock position. So these are the size for the primary internal pipes. So I'll repeat all these structures. First, we'll discuss about this. I clear up to here?